We had dispersed 10 minutes later, so we are starting at 1:10, just 10 minutes late. This scheduled session was on potassium, RAS inhibition, and the heart keeping life-saving therapies on track. And as we all know, cardiologists are usually they're in emergencies, so Dr. Kahli is not yet here. We are fortunate to have Dr. Shubhro Banerjee, who is supposed to take us to the second session targeting heart failure in LV ejection fraction greater than 40%, Finerenone, a new breakthrough. May I call upon stage the chairperson, Dr. Kaushik Munshi, who is a professor of এটা না পরেরটা যাবে এর পরেরটা যাচ্ছে বললাম তো এতক্ষণ ধরে শোন নেক্সটটা দিন Dr. Kaushik Munshi will be presiding over the session. Kaushik da always has me in my heart, as he did in the last HAPCON last Sunday. He says always Shomo is in my heart, but difference is I am in his right ventricle and he is in my left ventricle.
Thank you very much. May I start? Good afternoon, everyone. We have already completed my lunch. So now I don't have to say nothing about Dr. Shubhro Banerjee, very well-known interventional cardiologist. And the topic is also very different. Here the ejection fraction is more than 40% and the role of Finerenone. May I request Dr. Banerjee to please start his lecture.
So thank you, Dr. Munshi. It's my pleasure to be here. The mineralocorticoid receptor antagonist Finerenone is not unknown to the endocrinologists and the nephrologists. They have been using it for many years now in patients with diabetic nephropathy to reduce albuminuria and also to reduce the progression of renal damage. Now, there is also evidence from the studies that this medicine, Finerenone, also prevents or reduces the risk of heart failure in patients who has diabetic nephropathy. But recently, studies have also shown that Finerenone could be used for treatment of heart failure in patients who have an ejection fraction 40% or more. And this is what I'm going to discuss today. Now, as you know, heart failure clinically, not clinically, heart failure as such is actually divided into three categories depending on the ejection fraction. There could be heart failure with reduced ejection fraction if the EF is less than 40%. If it's more than 50%, it's preserved ejection fraction. And in between, it is heart failure with mildly reduced ejection fraction. Now, the heart failure, these entities, the phenotypes, actually they are quite different at the extremes. In other words, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction are actually distinct entities, and they differ not just by ejection fraction, but by other by other ways as well. For example, in heart failure with reduced ejection fraction, the systolic function is reduced, the heart is dilated, the hypertrophy or remodeling, whatever you call it, is eccentric, the volume of the left ventricle becomes larger, the walls are thin and stretched, contractility is reduced, so ejection fraction is also reduced, and consequently there's reduction in cardiac output. The myocyte becomes thinner but longer, And there is fibrosis resulting from necrosis. So the type of fibrosis what we find is a focal or replacement fibrosis. So all these things result in a reduced LV contraction, resulting in reduced cardiac output and reduction in ejection fraction. On the other hand, in heart failure with preserved ejection fraction, the dysfunction is diastolic, that it happens during the diastole of the diastolic period of the heart. There is concentric left ventricular hypertrophy. There is no LV dilatation. In fact, the LV cavity may become smaller. There is pressure overload as opposed to volume overload. The walls are stiff and thickened. Contractility is not reduced. It may be in fact increased as well, but the ejection fraction is preserved, but the cardiac output is reduced, and that's because despite the ejection fraction being normal, the filling pressure is high, and because of the filling pressure, the volume of the blood being ejected by the ventricle is less. Also, the myocyte diameters here they are thickened, and the myocyte length are not affected. And the type of fibrosis that you get over here is interstitial fibrosis. So basically, as you see, it's not just the ejection fraction which are different, but they are altogether different disease entities. Now we are going to talk on heart failure with preserved ejection fraction and mildly reduced ejection fraction, because that's where the finerenone has been found to be effective. Whether it's effective in those with ejection fraction less than 40%, we still do not know, because trials are on the way. But what we know is that although the prevalence of heart failure with reduced ejection fraction is somewhat static or gradually declining with time, those with heart failure with preserved ejection fraction are actually on the rise. And it's the number one cause for hospitalization in patients who are 65 years of age or higher. And we also know that 50% of patients who are diagnosed with heart failure with preserved ejection fraction are anticipated to die within 5 years of the diagnosis. So in other words, heart failure with preserved ejection fraction carry high morbidity as well as high mortality. Now the ESC guidelines have given SGLT2 inhibitors such as dapagliflozin and empagliflozin are class 1 indication for treatment of patients with heart failure with preserved ejection fraction, apart from diuretics and the treatment of the etiology leading to this heart failure. So where does the MRA finerenone lie? Now let's just switch gears and see what exactly is the role of mineralocorticoid receptors in heart failure. Now, in heart failure, what happens is there is stimulation and overactivation of the mineralocorticoid receptors. And this gives rise to two things. Firstly, there is sodium and fluid retention, so volume expansion, increase in blood pressure. Secondly, it also incites inflammation and fibrosis, which affects not only the heart but also the kidney. In heart, we get fibrosis, cardiac remodeling, and ultimately heart failure. In kidney, it causes glomerular injury, fibrosis, and leading to kidney failure. And we know that if you have heart failure, that can also increase chance of kidney failure and vice versa. So it's a cycle is actually started in case of heart failure, where MR, that is mineralocorticoid receptors, play an important role. Now, finerenone is one of the MRAs, that is mineralocorticoid receptor antagonist. Now, in compared to this is a steroidal MRA, non-steroidal MRA. In comparison to the steroidal MRAs that we have been using so far, for example, spironolactone, eplerenone, there are some differences. For example, finerenone is more potent than eplerenone, although it's similar in potency with spironolactone. It is more selective for the MR receptors, so they have less off-target effects like gynecomastia and menstrual problems. Hyperkalemia is increased with all MRAs, but it's more or less it's a bit less compared to that with spironolactone. Similarly, your risk of renal deterioration, and is also higher with spironolactone compared to finerenone. Now, it has been seen that finerenone, although it causes similar NT-proBNP reduction, which is a marker of heart failure, in comparison to spironolactone, if you look at the renal outcomes, for example, worsening kidney failure and hyperkalemia, these occur less frequently with finerenone compared to spironolactone. Now let's come to the subject matter for today's discussion, which is the role of finerenone in heart failure with mildly reduced or preserved ejection fraction. And recently this trial was done, which is called Fine Arts Heart Failure Study, and it actually compared finerenone to placebo in patients with heart failure and NYHA class 2 to 4 and ejection fraction 40% or more. These patients were randomized to either placebo or finerenone, a target dose of 20 or 40 milligram per day, depending upon the EGFR. So those who are EGFR was less than 60, where the target dose was 20, whereas those with EGFR was more than 60, the target dose was 40. And the primary, this was follow-up period was about 2.5 years, and the primary endpoint was the total number of cardiovascular deaths and total heart failure events. Total heart failure events first as well as recurrent. And the secondary endpoints were total number of heart failure events, KCCQ, TSS score, and the NYHA class, composite renal point, and all-cause mortality. Patients whose eGFR was less than 25 and those with potassium more than 5 were excluded from the study. Now, the patients who were recruited were actually divided into 3 categories, just to see like what's the effect on patients on the risk of heart failure. We all know that when our patients get admitted with heart failure, for a period of time, they are more vulnerable to develop another recurrence of heart failure, and with time, it gradually goes down. So here the patients were, all sorts of patients were included, those within 7 days of hospital discharge, 7 to 3 months, and more than 3 months. And the baseline therapy, as you see, was similar in the both groups. What the study showed is the primary endpoint, as the number of cardiovascular death and total heart failure events was significantly reduced with finerenone compared to placebo above the standard of care treatment. And it was, the relative risk reduction was about 16%, and the graph started to diverge from about 28 days. So in a month's time, you are going to see significant effect. And the effect actually was sustained over about 3 years of time. Now, coming to the secondary endpoints, the total heart failure events were significantly reduced, and so was the KCCQ TSS score in patients on finerenone compared to placebo. However, the NYHA class didn't show much of a difference, at least statistically, and since it was a hierarchical study, composite endpoints and all-cause mortalities were not studied. Now, it was seen that finerenone is effective regardless of the ejection fraction and the background therapy at baseline, irrespective of whether the SGLT2 was used or not. And if you look at the overall side effects, they were not similar, there was not a significant difference between the finerenone and the placebo group. And the discontinuation of the trial drug was also not significantly different between the two groups. However, hyperkalemia was more common among those patients who are on finerenone compared to placebo, though severe hyperkalemia, if you define it as more than 6 millimole per liter, was not that high compared to placebo. And another interesting thing is if you look at hypokalemia, which actually carries similar risk to that of hyperkalemia, even worse, even higher risk than hyperkalemia. The incidence of hypokalemia, which often happens in patients with heart failure, was reduced in those with on finerenone compared to placebo. And finerenone shows benefit across all subcategories, irrespective of the characteristics of the patient, the age, gender, BMI, race, the disease characteristics, like irrespective of the ejection fraction. It has to be more than 40 though. EGFR, UACR, systolic blood pressure, diabetes mellitus, and also the background therapy that the patient was. Now, the ESC guidelines haven't been updated yet, nor as the ACC guidelines, but there are certain guidelines which have been updated, and they have recommended Finerenone now as a class 2A indication for giving in patients with heart failure with ejection fraction 40% or more. And these are the iCardio guidelines, and this is the Japanese heart failure guidelines. So we all know that for heart failure with reduced ejection fraction, there are 4 pillars of therapy. That's beta blocker, or RAS inhibitors, MRAs, and SGLT2 inhibitors. And for heart failure with preserved ejection fraction, we already had one. That's SGLT2 inhibitors. Now we have the second one, which is the Finerenone. And very soon, I think, there would be other drugs like GLP agonists, and GLP-GIP agonist may come into the picture and become a pillar of heart failure treatment very soon for those with ejection fraction more than 40%. So there is a treatment protocol which is important to know if you are prescribing Finerenone, and we know, like, the one reason why MRAs are always used less often in patients with heart failure is because of the I would say anticipation of hyperkalemia, which is not unfounded, but again, if you know how to actually give prescribe correctly, then the chances of hyperkalemia would be less. So what you do in patients with ejection fraction for 40% or more and in heart failure, you check the EGFR and the serum potassium. If the EGFR is less than 25, do not start Finerenone. Similarly, if the potassium is 5, it's more than 5, then do not start Finerenone. But for those patients who JFR is between 25 and 60, start with 10 milligram of Finerenone and try to uptitrate it to 20 milligram. And for those whose EGFR is 60 or more, start with 20 and uptitrate to 40, so double the dose. Now, how do you do this uptitration? So you check, you ask the patient to come back, or after 4 weeks with EGFR and serum potassium results. If the potassium results is less than 5, then you double the dose. If the potassium is between 5 and 5.5, then you maintain at the current dose. If the potassium is more than 5, then you reduce the dose. And only if the potassium is more than 6, then of course you would hold it for a while till the potassium comes down to normal. Now, this practices may change soon, considering like we have your potassium binders currently available, which I'm sure would help patients to get more of MRAs, and that would help the patients to be on guideline-directed more patients to be on guideline-directed medical therapy. So that's what I have already said. And so finally, I would like to say that Finerenone has been so far indicated for adult patients with CKD, with diabetes mellitus and albuminuria, and it reduced, it slowed down the GFR decline. It reduced cardiovascular death, end-stage kidney disease, non-fatal MI, and hospitalization for heart failure. But now we can also treat these patients with heart failure and ejection fraction 40% or more with Finerenone to reduce cardiovascular death, hospitalization for heart failure, and urgent heart failure visits. Also, I would like to point to one important thing, that so far spironolactone or even eplerenone has not been approved to manage CKD patients with diabetes or to patients with heart failure with preserved ejection fraction with EF 40% or more. So thank you very much. So I would end here today, now, and if there is any question, I would be happy to take.
Actually, what is the future of this molecule as a cardiologist? We have to start with the basic drugs like the diuretic first, then gradually the other drugs like SGLT2. So what is the place of this, where to give this, when to give and where to give?
Correct. For example, in heart failure with reduced ejection fraction, we know now that although we have some 4 pillars and maybe 5, what they say is you go for a pillar approach. So you start all of them maybe in small doses and gradually build up the dose rather than the hierarchical approach which we initially did. For heart failure with preserved ejection fraction, we still do not know what is the best way to go forward, but there has been a study, for patients with diabetic nephropathy, the confidence study, where they actually showed that if you start both SGLT2 inhibitors and Finerenone together, rather than waiting for one to have its effect and later you add the second one, then you are getting better results. For heart failure with preserved ejection fraction, we do not have any trials as such yet, but I think if the patient, diuretics would be given to all patients who have congestion. When the congestion is relieved, then we have the SGLT2 inhibitors, which have been long been tested, and you start them on SGLT2 inhibitors. And I think these patients need Finerenone as well. Whether you need to wait for the SGLT2 inhibitors first to have its effect and then add Finerenone if the patient is still symptomatic is something we do not know yet. But I presume the same thing would be done or would be adopted in future as we have in for patients with heart failure with reduced ejection fraction and those patients with heart failure and your diabetic nephropathy. In other words, we should probably be using both of them together.
Thank you very much. Any question from the audience about the tirzepatide and the protection of the heart along with, if I add along with, you have already mentioned about the tirze.
Yes.
Yeah, they are also using in the heart failure even,
Yeah.
particularly.
Yeah, correct. We have.
Congratulations, a very nice talk. And what is your experience of patients? You have been through the, aldactone and then eplerenone, and then you have come into Finerenone. Compared to the previous two, what is the incidence of hyperkalemia, and what's your standard operating procedure regarding checking potassium? Once before and then in what frequency?
Yes. For MRAs like the steroidal ones, the eplerenone and the spironolactone, what we used to do is to check it within 2 weeks, probably after within 7 to 14 days, we used to recheck and titrate. But here, the investigators has given us sufficient assurance. We can, because the rise of potassium is slow, we can actually check it in a month's time. Now, in my practical experience, I have actually checked it in 2 weeks, just like the other MRAs. And so far, I haven't found any sudden rise in potassium. So I normally use now, once a month potassium checking to make sure that he's not developing hyperkalemia. Except, of course, in patients who have a low EGFR. Lower, it's not less than 25, but maybe something between 25 and 40 or something. In these patients, I do it sooner.
So CKD3B, you do it more frequently?
I do it more. There's no guideline to say that, but that's what I do, myself.
Thank you. Any other questions from the audience?
So I have to conclude the session. If there is any question, you can ask even later on. So I have to conclude this session. It's a fantastic lecture, Dr. Banerjee.
Big round of applause to Dr. Banerjee, please.
Thank you very much.
Thank you so very much. And, well, just a minute, sir. Sir, back to stage. So, to do the honors, could I request Professor Demalo Shannal to present the mementos to give to Dr. Kaushik Munshi, and and now to the speaker. So as the non-steroidal MRIs are not having any great impact on rising potassium, I do not know how Localma will build its market. So for the next session, Well, we are going back one session, one step back, a strategic. What do you have? The potassium, the RAS inhibition, and keeping the heart, keeping life-saving therapies on track. And to present it is none other than two great friends. One as a speaker, Dr. Dhiman Kahali, and other as a chairperson, Professor Dr. Debmallo Sannal. So, Dr. Sannal, the honors is all yours.
I think Dr. Dhiman Kahali doesn't need any introduction. He's associated with BMBLA for 37 years and he's ex-chairman of National Intervention Council, as well as, and he's had several awards, including the Gandhi Centenary Award, as well as the Mother Teresa International Award and International Guest Faculty Award, to name a few. Over to you, sir, to take us through this new molecule.
Thank you, Debmallo, for your kind referral. Incidentally, I am also the president of our Cardiological Society of India. So today they have asked me to talk about potassium, RASI, and the heart, keeping the life-saving therapies on track. So just now we heard a beautiful lecture from my brother and friend, Shubhro, who gave an excellent lecture. But as I was listening to comments by one of us, that finerenone doesn't cause hyperkalemia, that is not true. Finerenone also do cause hyperkalemia, but it is little less than spironolactone, and it's equipotent. Spironolactone and finerenone are equipotent, but eplerenone is definitely less potent than spironolactone and finerenone. So our concern for hyperkalemia is always there. And in about 35 to 40% of the patients, we can't give the patient with heart failure the benefit of RASI therapy. And that's something criminal on our part, but we can't help. Just to tell you, right now I have a patient who has been suffering from HEP-REF for last 25 years. He had a bypass, he had a CRT, and he is on treatment. So I have kept on very low dose of spironolactone, say twice in a week, some modifiable. But his creatinine went up suddenly from 1.6 to 8.2. So I stopped everything. This finerenone, Kerendia, and everything I stopped because it was not possible. And you won't believe, within 3-4 days, it came down from 8.2 to 2.2. So that is the effect, and it doesn't happen suddenly. I have the experience with enalapril. I gave 25 years, 30 years back to one of my lady patients with, hypertension, and little LV ejection fraction was little down, 50-55%. And you won't believe, I had to put, even I couldn't go. My resident had to put a temporary wire inside because the potassium was high, with 5 milligrams of enalapril, and there was no history of any kidney disease and might have been renal tubular acidosis, as you tell. So these are the different grades of hyperkalemia and hypokalemia. And regarding hypokalemia, first I want to tell that these are the causes. You can teach me. But what is important, if you go to the previous edition of Drugs for the Heart, edited by OP, and he has stopped editing the book, and it's presently by Dr. Deepak Bhatt. And Dr. Deepak, I don't know whether he has written or not, but Dr. Bhatt is currently the editor. And there it was written in the previous edition that if a patient's potassium is 3.8 and another person's is 4.5, the person with 3.8 has 400% chance of mortality from arrhythmias. So it is written in his book. So that gives some indication, as Shubhra was rightly talking, that hypokalemia is also similarly as dangerous as hyperkalemia. And the increase in serum potassium may be due to the reduced kidney function, chronic treatment with RASI, which is the commonest cause with all of us. We endocrinologists, we cardiologists, all of us treat HEP-REP patients, and also acidosis. That's also an important factor which we should not forget. So it's very important for all of us to keep the patient eukalemic, means the potassium should be around 4.3, 4.4 to 5 within it, maybe around 4.5 to 4.8 preferably. And these cardiorenal patients are at an increased risk of hyperkalemia, and these are the different population as depicted by him, my previous speaker. CKD, up to 40 to 50% of patients in advanced stages of CKD, especially with diabetic, and on RASI therapy, they